Leptospirosis, microbiology and epidemiology. Leptospirosis is one of the most common zoonotic disease, favored by a tropical climate and flooding during the monsoon, but occurring worldwide. Leptospirosis are tightly coiled, thread-like organisms about 5 to 7 micrometer in length, which are actively motile. Each end is bent into a hook. Leptospira interrogans is pathogenic for human. The genus can be separated into more than 200 serobars belonging to 23 serogroup. Leptospirosis is ubiquitous in wildlife and many domestic animals. The organism persists indefinitely in the convoluted tubule of the kidney, are shed into the urine in massive number, but infection is asymptomatic in the host. The most frequent hosts are rodents, especially the common rat, Ratus norvegicus. Particular leptospiral serogroup are associated with characteristic animal host. For example, Leptospira icterohemorrhagia. Leptospira icterohemorrhagia is the classical parasite of rats, and Leptospira canicola of dogs. There is nevertheless considerable overlap in host serogroup association. Leptospira can penetrate insect skin or mucous membrane, but human infection is facilitated by cuts and abrasion. Prolonged immersion in contaminated water facilitates invasion, as spirochete survives in water for months. Leptospira is common in tropics and also in freshwater sports enthusiasts. Clinical feature: after relatively brief bacteremia, invading organisms are distributed throughout the body, mainly kidneys, liver, meninges, brain. Kidney, liver, meninges, and brain. The incubation period averages 1 to 2 weeks. 4 main clinical syndromes can be discerned, and feature can involve multiple different organ systems. Figure 1326. Clinical syndrome of leptospirosis. In acute bacteremic leptospirosis, aseptic meningitis. Aseptic meningitis is for presentation with headache, photophobia, eye conjunctivitis, uveitis, jaundice. Epistaxis, nosebleeds, epistaxis, hematemesis. This is Wells disease, uveitis, jaundice, epistaxis, hematemesis, pericarditis, myocarditis, vasculitis, hepatomegaly, diarrhea, vomiting, renal failure, myositis, pulmonary syndrome, hemoptysis, pulmonary hemorrhage, acute respiratory distress syndrome, leg transient macular rash, purpura, bruising. Bacteremic leptospirosis. Bacteremia with any serogroup can produce non-specific illness with high fever, weakness, muscle pain, tenderness, especially of the cup and back. intense headache, photophobia, sometimes diarrhea, vomiting. Congenital congestion is only notable physical sign. The illness comes to end after about 1 week, else merge into one or other form of infection. Aseptic meningitis, classically associated with Leptospira canicola infection. This illness is very difficult to distinguish from viral meningitis. The congenital may be congested, but there are no other differentiating signs. Laboratory clues include neutrophil leukocytosis, abnormal LFTs, and occasional presence of albumin and cast in urine. Icteric leptospirosis Wells disease. Fewer than 10% of symptomatic infection result in severe icteric illness. Wells disease is a dramatic, life-threatening event characterized by fever, hemorrhage, jaundice, acute kidney injury. Congenital hyperemia is a frequent feature. The patient may have transient macular erythematous rash, characterized skin changes are purpura, large area bruising. In severe cases may be epistaxis, hematemesis, melena, leading into pleura, pericardial, or subarachnoid spaces. Thrombocytopenia, probability to activation of endothelial cell with platelet adhesion aggression, is present 50% cases. Jaundice and hepatomegaly usually occur without hepatic failure or encephalopathy. Acute kidney injury primarily caused by impaired renal perfusion. Acute tubular necrosis caused oliguria, anuria with albumin and blood and cast in urine. Wells disease may also associate with myocarditis, encephalitis, septic meningitis. Uveitis and iritis may appear after months clinical recovery. Pulmonary syndrome. This syndrome has long been recognized far east and has been described during an outbreak of leptospirosis in Nicaragua. It is characterized by hemoptysis, patchy lung infiltration, chest X-ray, respiratory failure. Total bilateral lung consolidation and ARDS with multi-organ dysfunction develop and mortality is high over 50%. Diagnosis polymorphonuclear leukocytosis, accompanied severe infection by thrombocytopenia and elevated blood level of creatine kinase. In jaundice patient, there is hepatitis. Prothrombin time may be prolonged. The CSF in leptospira meningitis has variable cellular response, moderately elevated protein level, and normal glucose concentration. Acute kidney injury due to intestinal nephritis is common. In tropics, dengue, malaria, typhoid fever, scarf typhus, hantavirus infection are more important differential diagnosis. Definitive diagnosis is leptospira depends on isolation of organ, enzyme and serological test detection of specific DNA. In general, however, it is possible to underdiagnose. Blood culture are most likely to positive if taken before day 10 of illness. Special media required culture may have to be incubated for several weeks. Leptospira appear in urine during the second week of illness, and untreated patient may be recovered of culture for several months. Serological tests are diagnostic in cell conversion or fourfold increase in titer demonstrate the microscopic agglutinin test. It is the investigation of choice and can be positive either first week. Microscopic agglutinin test is an investigation of choice and can be positive by the end of first week. IgM, ELISA, and immunofluorescence technique are easier to perform. However, the rapid immunochromatographic tests are specific. They are of only moderate sensitivity in past week of illness. Detection of leptospira DNA by PCR is possible in blood in early symptomatic disease and in urine day 8 of illness and for many of other therefore. Management and prevention. General care of the patient is critically important. Blood transfusion for hemorrhage and carefully attention to renal function. The causes of death are especially important. Acute kidney injury is potentially reversible and adequate support such as dialysis. Most infections are self-limiting. Therapy with either oral doxycycline 100 mg twice daily for 1 week or intravenous penicillin 900 mg 4 times daily for 1 week is effective but may not prevent development of renal failure. Parenteral separation 1 gram daily is an effective as penicillin. JHR may occur is usually mild. Uveitis is treated with a combination of systemic antibiotic, local glucocorticoids. There is no rule of routine use of glucocorticoid in the management of leptospirosis. Trials in military personnel have shown infection with leptospira interrogans can be prevented by taking prophylactic doxycycline 10 mg weekly.